Okay, so let's begin. Hello, good evening. Welcome again, everybody, to this amazing cardiology revision session. Again, we are going to rapidly revise some of the recently upcoming high yield MCQs for cardiology that are really gonna come up in some or the other ways in your upcoming exam on 24th of August for your MRCP Part 1 examination. So we have already waited a lot. Let's jump straight away into it. So okay, so let's begin the first one here. And you will notice that most of the questions that we are going to deal today in cardiology are exactly like how your patient presents to you in acute medicine setting. So hello Pavan, hello Karthik. I hope I'm audible to all of you today, and that's not an issue. Okay, so Pavan is quick to answer here, and let's see, breaking the silence. Karthik, I'm expecting an answer also from you. All right, so going ahead with the answer of this one, let's go through the question quickly. The first word of importance is asthma. Came to the emergency department, so the patient came in an acute setting. Okay, then patient had palpitations. Okay, and duration of the palpitations. So it was of acute onset, not a long history. Okay, the patient has a previous medical history of CCF. That is important. The moment you see any structural heart disease or anything like a history of ischemic heart disease, something you can rule out straight away is flecainide. Flecainide is a wonderful drug, but some trial like CAST trials, as they suggested, it shouldn't be used in cases of structural heart disease. So the moment you see ischemic heart disease or structural heart disease related with any rhythm disturbances, go ahead and rule out flecainide straight away. Now let's move ahead. Now, also to be noted here is that you have seen asthmatic patient, so beta blockers are ruled out as well. Okay. So anyways, we are left with only two options here. Now, the thing is blood pressure of the patient. Yes, Karthik, you're right. Asthmatic, so atenolol is contraindicated. Hello, Dr. Hiren. And the thing is, most of you have answered C because of the blood pressure. But as we will note here is that the answer to this could be either amiodarone or DC cardioversion. Okay, so the differential is here, and the patient is already in AF. So what we'll do is we'll try to figure it out. The correct answer to this one will only depend on one thing, that is blood pressure. Now, if the patient shows hemodynamic instability, now this is basically hemodynamically stable patient. Okay, so let me write it again in a fresh page for you. So in our current question, what we need to understand is that the patient first thing you have to see is hemodynamic. So the cutoff values for RCP examinations is 90 by 60 millimeters of mercury. Anything below this, you will go for DC cardioversion straight. Okay. So if it is less than this, then you will go here. If the patient is hemodynamically stable, you will then go for amiodarone. Okay. So don't get confused. Look at the blood pressure values carefully and look at the general overall condition of the patient. Also, in cases of a planned DC cardioversion, when you are going to give a patient, then you have to give the patient at least 6 weeks of anticoagulation before moving on to DC cardioversion. All right. Another thing, it doesn't usually come up, but you always have to go for a synchronized shock in case if the question is tested, or else you are going to end up with R-on-T phenomenon for the patient. Now coming over here, amiodarone is the most suitable choice in this particular question. Remember that flecainoid is contraindicated in structural heart disease. Also remember that beta blockers are contraindicated in asthmatics. Also remember that you will always prefer in an acute setting, you will prefer rate control over rhythm control, because for the rhythm control the patient could be in chronic AF, so then you are not bothered so much as you are bothered about rate control in an acute setting. Okay, and we can talk about rhythm control in a chronically patient who is suffering from AF in a chronic way. Okay, so the right answer for this one is amiodarone. And this is a general list where you will find that this will also deal with your clinical sciences question. You will also see that amiodarone not only covers class 3 but also covers all the classes, that is 1, 2 and 4. So this is basically a very sort of broad spectrum drug, and please note that you can fill this table up, so I'll just write it down for you. All right, so this is how you will go ahead, and calcium channel blockers are also a good choice in cases of PSVT. All right, let's move on to the next one. I'm happy to see that all of you are answering today. Okay, so Dr. Hari and Dr. Karthik are quick to answer this one. Yes, the answer is atenolol, and we'll quickly see that this is a small chart. You can go through this. I've prepared a figure MI can cause CHP. Yes, you're right, Dr. Hiran. What you need to understand over here in cocaine-induced MI is that basically cocaine increases your noradrenaline and dopamine levels. So you can think of it like a sympathomimetic agent. After the class, please make sure today to go through the notes. I have prepared the notes in such a way that it will cover most of the things in detail, so it will help you a lot. So what cocaine does is it increases the noradrenaline and dopamine levels. So now what happens is at your alpha receptors, via the stimulation of this, it causes vasoconstriction. Okay. Now when you have you give a drug called beta blockers, you will be unmasking it, and then only alpha receptors will be getting stimulated. So then that will cause a massive vasoconstriction, and you cannot reverse that. So that will be very much fatal to the patient. So you have to avoid beta blockers. Okay. This vasoconstriction also happens in your coronary arteries. So the oxygen demand of the heart is not met, and you have to avoid beta blockers in such a case. Now, you should remember that the answer to this one in another sort of a question, it very much behaves like your normal MI. So if there is a clear-cut ST elevation MI, even if the cause is cocaine, the treatment modality will remain the same. That is urgent PCI. Okay. I hope this is clear. And since all of you are anyways answering correctly, I am very happy to see that. And this causes vasoconstriction, tachycardia, all your sympathomimetic action, and increase myocardial auto demand. All right, moving on. Let's try this one. Okay, so okay, so Punmagar is quick to answer this one, and Kartik Priya is also saying C. Dr. Aisha says C. Dr. Hiren says C. So going with the consensus, who am I to change your answers? It is aortic stenosis. This is how a stenotic valve behaves when you actually look at the cross section of it. And this question is a very important question, I have put down a chart over here for some of you who have a difficulty in remembering how any murmur behaves. Okay, so you can go through this. You can even put it up at a place where you can look at it clearly. Now, let's talk a little about aortic stenosis. Any old patient, this could be age-related calcific stenosis or some other cause could also be there. Now, you will have an ejection systolic murmur over the aortic area, and it will radiate upwards towards the carotids. That's a classical description of AS on auscultation. Also, the pulse will be slow rising pulse in a stenotic valve, and the history will definitely mention history of dizziness and collapse. Okay, in some cases you can have displaced apex beat, but that's not a necessary thing. Um, Dizziness and collapse is a very good pointer towards aortic stenosis. Okay, there are certain points that you have to remember in dealing with AS cases in your questions. First of all, you have to differentiate it between coarctation of aorta and aortic stenosis. Now, it will not be very difficult, but sometimes you have to remember that the in a patient with coarctation of aorta, there will always be a hypertensive patient, wherein the blood pressure measurements within the arms and the lower limb, that is the femoral pulses, it will be different. Okay, and usually the femoral pulses, like the blood pressure, is higher than the arms, but then it will be reversed in the cases of coarctation. So that is how you will differentiate between the two. Also, AC inhibitors are strictly contraindicated in severe aortic stenosis. Most important diagnostic factor, if you have to decide between whether the patient is getting a replacement of the valve or not getting the replacement, is symptoms. If the question mentions that the patient is getting dizziness, a patient has had an episode of collapse or 2-3 episodes in the previous 1 month or so, then it's a very clear-cut indication of replacement of the valve. But even if the patient has a very good stenotic valve and he is symptom free, you do not have to go with AVR, that is AV valve replacement. If you opt for an option wherein there is a given option for AV replacement, try to look for an option where it is being done concomitantly with PCI. Okay, so if you are performing a coronary angiography, you have to choose the choice wherein the AV valve replacement happens together with coronary angiography or angioplasty if required in the OT setting. Okay, so do not base your decision based on the gradients. Pressure gradients are relevant, but then they are not very much relevant for the cases of AVR, that is replacement. Symptom is the most important thing. All right, so you can just go through this. These are certain features that are there, and it's a good cause of reverse splitting of S2. You have to remember that, and that's pretty much it. Let's move on to the next question. Okay. Unmagar says B, Dr. Aisha says E. Anybody else wants to take a try? There is no negative marking. Someone says A. Okay. We're basically talking about Okay, Regina says E, and Adrian says something, and Karthik says E. So I've got 3 for an E. So the correct answer for this one is hypokalemia. It's, if you remember the cause of it, you could rule it out just by looking at it. All the other causes are A, B, C to D. Now, yeah, so let's move on. So these are the causes for your long QT syndrome or prolonged QT interval. You have familial causes. In your familial causes, remember that there are only 2 that you need to remember. So the first one is Romanov-Ward, and the second one is Javel-Lange-Nielsen syndrome. In the second one, there will be presence of profound hearing loss. So that's the only thing that you have to remember. Okay. So this is the only differentiating factor between the two. And Romanov-Ward is the most common cause of long QT syndrome. As you can see in the metabolic causes, all of these causes are hypo. Okay, so I have put it down so that you can remember it clearly. So don't get confused. It is very easy to get confused during the exam also. So remember this, all the hypo causes prolonged QT interval. Okay, when you move towards hyper, it goes towards shortened QT interval. All right, and certain drugs, these are antiarrhythmic drugs, right? So they are bound to do that, that is prolonging the interval. So don't get confused, all the hypo causes prolonged QT interval. I think I've made my point very clear. All right, moving to the next one, and most of you have answered it correctly, don't worry. Yes, Punmaga, you're right, and that's how you have to remember it. Hmm. Okay. All right, so most of you have answered it correctly now. The answer is hypertrophic cardiomyopathy. And yes, Karthik, you're right. So the thing with HCM is it's an autosomal dominant condition. Yes, it is. What you need to remember for your exams is that the genes encoding beta myosin, these are your point of mutation. And this will not only be tested in cardiology, but also for your basic clinical sciences. Okay, there are other things like tropomyosin and troponin T. You don't have to worry about that. All you need to remember is beta myosin in cases of HCM. Whenever you see a question, okay, so whenever you see a question dealing with any young adult or athletes having a history of sudden cardiac death, you have to think of hypertrophic cardiomyopathy. Most important is that there will be other cardiomyopathies also given in the question stem, but it will be the HCM is asymmetric septal hypertrophy. Okay, so that is the classical point. How we used to remember is like SAM and ASH. So SAM is systolic anterior motion of the mitral valve, and asymmetric ASH means asymmetric septal hypertrophy. So that is how, if the echo findings are given and they are asymmetric, then it's classic pointer towards HCM. Family history of sudden death at a very young age in athletes, just go ahead with HCM. All right, we'll take a look at the things we have provided here. Symptoms are very vague. So sudden death may be the first symptom in HCM. Jerky pulse, it will not be given, but in clinical cases you can see that. Also harsh ejection systolic murmur. Okay, in ECG you will see LVH, of course you will see LVH, and you will see deep Q waves. Okay, in the inferior and lateral leads. It's a classic cause of AF and WPW syndrome, so don't forget that. And treatment modality includes, if patient has AF, then you have to add amiodarone. If other things are present, then most probably beta blockers and amiodarone will be given. and the question will ask you to consider for long-term therapy, so that will be an implantation of an ICD. Okay. Don't go for septal myomectomy. This is never the right answer for RCP. Okay. All right. Let's go for the next one. This question is something that doctors don't like to remember, but it is what it is. You have to remember that. Hmm. Junaid says B, Karthik says C. So what's the point of confusion? Let's find out. So the important thing to note over here is the patient was fit for discharge 48 hours later. That means that our angioplasty was successful, right? This means that the angioplasty was successful. Now the guidelines are slightly different for successful and unsuccessful angioplasty. So sorry, I'll just mark the right answer here. So the right answer is 1 week, and why not 4 weeks? I'll just get to that. If you look over here, if at all you can see, don't worry if you can see right now. For angioplasty, it's very simple. It will only be two things, 1 week or 4 weeks. Okay. If the angioplasty is successful, you have to stop the patient from driving for 1 week. If it is unsuccessful, then you have to stop the patient for 4 weeks. Okay. That's how it is. Also, in cases of CABG, post CABG patient, you have to, if it's a surgical case, you have to stop the patient for 4 weeks. Okay. And I think that's, yeah. There's one more thing. You do not need to inform the DVLA in these conditions, but you have to advise the patient not to drive for such duration. Okay. DVLA need not be informed in this case, but yes, you have to stop the patient. This DVLA thing will also be there in neurological and other things. So simply for cardiovascular causes, you can see here, and you can just remember this. In neurological thing, a TIA or a stroke, okay, so that is 1 month, and in cases of unprovoked seizure, that is 6 months. Okay, and after 6 months also the patient needs to be evaluated whether the patient can drive or not, after the patient has been stabilized on drugs. Okay, so that's how you have to remember this. Another thing before moving on to the next one, there are certain clauses, the legal clauses, for how long a patient, if the patient shows any psychiatric symptoms, how long you can detain the patient. Please go through that, and it's a list. I'll try to provide it in the next class. So just remember that, because you can expect one question in the basic clinical sciences or in psychiatric, whichever, but you have to remember that. It's very important. Okay, let's talk about infective endocarditis. Okay, so all of you are saying mitral valve. Most likely that is the most common place. Yes, mitral valve. Yes, you are all correct, and I'm really happy to see that. This is the decreasing order of frequency for valvular involvement in infective endocarditis. You have to remember that the vegetations, they occur on the lower pressure surfaces. Okay, so for example, if you take the mitral valve, it will occur on the outer, that is the aortic surface. If you take the aortic valve, then it will occur on the ventricular surface. All right, so that's how it is, and most of the causes will be, if the native valve is involved, then it will be strep. And staph will have a very acute and very aggressive course, so the history will be very short. Okay, but if they are asking you about the most common cause now, then the answer will be staph. All right, I hope all of you are familiar with the major and minor criteria, and if you're not, then please go through that. Okay, so all of you are correct. So if you have a strep bovis, it comes basically from colorectal cancer or adenoma. So once the patient is ready for the procedure, you can perform colonoscopy. Okay, so that's the point here. Also, you have to make sure that before opting for colonoscopy, if it is asking about the immediate procedure will not be colonoscopy, because you have to see whether the patient is stable or not, or the patient is fit for the procedure or not. Do make sure of that. Just think of it like how you would see a normal patient. Most of your answers will be correct if you deal with the questions like how you're seeing a regular patient. Okay, so prosthetic valve infections, we will likely to see staph aureus, and yes, cons, that is Coagulase negative staph, is also the cause. But in cases of prosthetic valve, please remember that the most common cause will be staph aureus. And yes, the cons is also an option, but this is a better answer. Okay. And eventually all of like 20 to 30% of the walls are likely to get infected. If metallic walls are involved, then they are infected earlier, and bioprosthetic walls are infected later. That's the only difference. Okay. There are other causes also, like alpha hemolytic streptococci and enterococci, but see, they are lower down the ladder. Okay, so the most important one will be Staph aureus always. All right. Pun Magar is quick to answer this one. And yes, Pun, you are absolutely correct. The correct answer for this ASD is ostium secundum. I've put up a small table over here for you. So if you note a partial right bundle branch block with right axis deviation and prolonged PR interval, yes, Dr. Hiren, Dr. Pawan, Dr. Karthik, all of you are correct. Yes, and Dr. Aisha, you're right as well. You have to note that the partial and right axis deviation points towards ostium secundum, while left axis deviation, if mentioned in the stem, points towards ostium primum. Okay, so just make note of that. And in ostium primum, you will also have a first degree heart block. So this is something that comes up in your exam. They can also ask you where the defect is there in the anatomy of heart. All right, so most of you are correct. Please make sure to go through the notes really well this time, because I have put up some things that you need to remember, and try to put them up in a table sort of format so that it's easy for you to remember. Okay. So Dr. Pavan, please note here that new onset left bundle branch block is an important thing, and it is a very good indication for thrombolysis. Okay. So C is the right answer here. So basically, you do not do thrombolysis when it's 1 mm in your chest leads. Rather, you do thrombolysis when it's 2 mm in your chest leads and 1 mm in your limb leads. Okay. Let's talk about some of the contraindications. So if a patient has had a recent bleed or hemorrhage, if the BP, let's say, is recent blood pressure is more than 200 over 100 or something, so basically very heavily hypertensive. Okay, so any recent head injuries, this is a major contraindication. and recent surgery or trauma. Okay, so these are your relative contraindications. In cases of suspected aortic dissection, you suspected, so you don't have to thrombolyze the patient. Okay. Uh, yes. So most of you are correct in this one. There's a small thing I would like to mention here. Uh, let's talk a little about the Vsds, that is the ventricular septal defects. Now, in cases of, let me just add over here. I'm sorry, I'm going back to this question, but there are certain features that you need to know so that you are prepared for these words. These are the words that you will encounter in your exam. Okay, so this is how your VSD presents to you in your exam, and the associations like pulmonary hypertension, atrial fibrillation, etc. These will be there, and also let's talk a little about PDA. So a continuous machinery murmur. Remember this term, continuous machinery murmur. This will be present only in case of PDA, and you will have a collapsing pulse. And you will also have a left to right shunt. The drug you need to remember in PDA is indomethacin. It closes the PDA. Okay. And if you want to keep the PDA open, you have to use prostaglandins. Okay. So, yeah, in tetralogy of Fallot, you will have a paradoxical embolus. Okay. And you can have a right ventricular heave. I know it must not be visible very clearly right now, but when you download it, it will be all fine. And if this is a case of cyanosis, can be present in cases of right to left shunt. Okay. That's it. And for investigations, you can do the bubble studies. All right, so that's about it. Let's move ahead and let's try this one now. Okay, I think most of you have answered Warfarin, which is the right answer here. So 65-year scores 1 point on the new CHADVAS scoring, which is the new CHA2 DS2 VAS scoring for anticoagulation. All right, you have to go through this. In the moment you pick up anything from this one, because in our case, the patient scored a 65 years, 1 point on age. 1 point scores warfarin preferred over aspirin. So in case if you have to give anticoagulation, then you have to go for warfarin in this case. The whole idea of the scoring system is whether you have to use warfarin or not. There is no role of aspirin anymore, like previously it used to be when we had the CHAD S2 scoring, this one, but that's not relevant anymore. This is not used anymore. Okay, so just go through this. You will not be asked to score in your examination, but you will definitely be asked about whether you have to give anticoagulation or not to the patient. I'm happy that all of you have answered it correctly. Okay, this is a very simple one for most of you, I guess. Okay. The question reads, the patient is able to conduct his day-to-day activities free of symptoms, but that doesn't mean that he is absolutely free of symptoms. He is getting breathlessness and he's trying to walk uphill briskly. Okay, so first of all, there is no grade 0 in this one. Okay, and grade 1 is basically nothing. So when the patient has no symptoms at all. Okay, so no breathlessness, no effect on day-to-day activities. But the patient does have symptoms. Okay, so we cannot rule out this one. So this will actually be grade 2. If it was a, you can look at it reverse way. Okay, so when the patient has a grade 4 like heart failure classification stage, so when the patient is grade 4, this is the symptoms are present even at rest. Okay, let's actually go through the table. All right, if you look at it over here, go through this in a reverse order. So grade 4 is your patient who is unable to do anything, and even when the patient is at rest, the activities, he has breathlessness. Then comes mild exertion, then comes severe exertion, and then comes no breathlessness at all. So the question here has mentioned breathlessness, and you cannot skip that. So make sure of that. So severe exertion, like briskly walking uphill, is classification for severe exertion. Then the question mentions like the patient walks on a straight floor, goes to the washroom, and then he feels exerted, like he feels breathless and he feels dyspneic. So that is grade 3. And the person who cannot conduct his day-to-day activities without help is grade 4. Okay, I hope that solves some of your queries. So let's talk about this one now. The whole idea about putting this question over here is this. Okay, so all of you say E, and E is the correct answer here. Um, when we are talking about hypertension, we follow the ABCD rule, right? So in the ABCD rule, this is nothing but when you have a young patient, A means AC inhibitors, B means beta blockers. Actually, I'll write it here. Okay, and C means calcium channel blockers, and D means diuretics. And when you encounter a normal patient, young patient, this is how you go. First, you start the patient on AC inhibitor, and then you go on adding beta blockers, and then calcium channel blockers, and lastly diuretics. Okay, but in cases of patients over 55 years of age, and in cases of, you start from here, in cases of patients of a particular ethnic origin, that is Afro-Caribbean, you have to start with calcium channel blockers, the reverse order. Okay, so if you have an older patient, let's say around 65 years of age, presenting to you for the first time being hypertensive, you start with calcium channel blockers and then you move towards this. Like then you add probably an beta blocker and then go on adding an AC inhibitor. But in cases of a normal young patient, this is how you go down the ladder. Okay, go C, B, A. But here you go A, B, C, D. Okay, so I think that clears most of the thing. Okay, we'll solve this one and then we'll go for a quick break. And if the question mentioned most sensitive, you have to answer that also, because I think most of you are using it in your day-to-day life. But here the question is asking which is the first enzyme to rise in cases of an MI. Oh, the Regina is very quick to answer. Okay. Anybody else wants to take a shot? All right, so Regina, you're right. Myoglobin is the first one to rise, and here's the table. Now LDH, this is basically the onset. Okay, how quickly after the onset of an MI will these enzymes rise? Yes, Dr. N. Pawan, you are right. Pawan, it's D, myoglobin, and probably I think you're answering the one which is most sensitive. So if you were asked about the most sensitive, then this would be TROP-T, like how most of you use it. Okay, so this is the first to rise. Okay, myoglobin. If you see here, it just rises within 1 to 2 hours, and TROP-T takes approximately 4 hours initially to show any rise in the levels. The reason why we do not repeat TROP-T is it takes approximately 7 days to normalize. So you cannot repeat it to check whether you're having a repeat MI or not. That is why you use some other tests. Okay, that is the reason why we don't do a repeat TROP-T once it has come positive. All right, so I hope you guys are enjoying right now. Gonna take a quick short break for 10 minutes exactly, and then we are gonna come back. So stay tuned. See you quickly. Hello guys, I hope I'm audible right now, and sorry for the short delay. There was some issue with the audio. So yeah, let's get back to our questions. Please let me know in the comments if I'm audible or not. Okay, Dr. Hiren is quick to answer this one. Thank you, Dr. Asha, for the feedback. So yeah, um, you're right. We are talking about Wolff-Parkinson-White syndrome. This is SVT, that is supraventricular tachycardia. You have an accessory conduction pathway. Okay, basically you have an accessory, okay, conduction pathway. So if you see over here, I'll just change the color so that it's visible. This is the way it would look like if it was a normal. Okay, this is how your normal P and then Q and R wave would look like. But in cases of WPW syndrome where you have an accessory pathway, so this is quick to depolarize here. So this is what is your delta. Now how the term delta comes is because it looks like delta. Okay, so that's how it is. Now you will have a left axis deviation in left sided pathway and vice versa. That is right axis deviation in a right sided pathway. You will also have a short PR interval you will have the widened QRS with slurred up stroke, that is delta wave. And you will also have treatment would be RFA, radio frequency ablation is the definitive treatment. So any young patient, if patient is undergoing radio frequency ablation, WPW is a strong contender. All right, that's about it. Let's move on to the next one. So for the previous one, Dr. Hiren, Dr. Pawan, Dr. Karthik, all of you were right. And this is something that Dr. Hiren was mentioning previously in some other question. He was talking about this, I suppose. Yes, Dr. Hiren, Dr. Karthik, you are absolutely right. ST elevation in the leads 2, leads 3, and AVF is the correct answer for inferior ST elevation MI. If you look over here, I have put up a small chart for those of you who have a little bit of difficulty in understanding which lead points towards which one. So this is how your basic ECG looks like. If you have a 12 lead ECG, this will be distributed in this pattern. So your lead 1, lead AVL, and V5 and V6. Let me draw it very quick in a rough diagram for you to understand. So Okay, so this is corresponding to your alright, so this is how it looks. If you go this side, it will be something like that. Okay, so this is how it goes. It's on a plane which is perpendicular to your heart, and that's how we measure it. Okay, so these are the lateral areas, V5 and V6, and V3 is usually septal, V2 like that. Okay, and this is the table that you should be very well versed with, not only for your exams but also for localizing the ischemic zone in case you are asked to deal with an ECG. Okay, make sure that you remember this chart really very carefully. Okay, I hope this will help you. So let's go move on to the next one. Please remember, you are not going to get any images in your part 1 examination, so all of these images are to help you out in remembering the stuff. So don't worry about any images. Whatever are the findings of ECG, it will be written very carefully in your question stem, so don't worry about it. Okay, don't worry about remembering exactly how it looks, rather identifying it on the real ECG, but rather just remember what are the terms, what are the leads that will point towards, let's say, LED, so like that, anteroseptal or anterolateral and all. Okay. Hmm. Okay, Dr. Junaid is really very quick to answer that one and correctly. Dr. Hiran says D. Dr. Karthik says D again. Anybody else? Okay, so I suppose you all picked up on the positive small sign over here, which is usually negative in cases of cardiac tamponade. Also, differentiating it from cardiac tamponade is, if you look at the history, the duration of the history is very important. If the patient is deteriorating rapidly, it's usually cardiac tamponade, and Kussmaul signs is negative. Also, you will not have Y descent in cases of cardiac tamponade. So let me write that first, because that's emergency. Uh, you can have many causes for constructive pericarditis. I'll list down a few for you to remember. Okay. Tuberculosis and uremic pericarditis is also something you should be on the lookout. And I don't think asbestosis will be an issue for you, because you will also find this chest was clear on auscultation. So you will find the fine crackles which are present in asbestosis. And in SVC, you will have elevated JVP, and A waves and V waves will be absent. So elevated JVP is very important for SVC. You can also expect questions on SVC, okay, and facial swelling and dilated veins will be there in SVC, okay. SVC is an important topic for exams as well. This could be post-infective, and this could be recurrent. This could be a connective tissue disorder. This could be due to tuberculosis. This could be due to uremic pericarditis. Unusual cases, you can also find radiotherapy as a cause. Okay. As we see, there will be classical description of facial swelling. So don't miss out on that, as well as you will have raised JVP. Okay, I think that's enough for this question. Let's move on. Okay, Dr. Karthik Priya is quick to answer that one. So all of you agree with me on B, that is Dressler syndrome. That is good. Dr. Punmaga, Dr. Junaid, Dr. Hiren, all of you are right. This is Dressler syndrome. In a question stem, you will only have to differentiate between Dressler syndrome and the reinfarction. So the timing is what will differentiate between the two. So basically, this is pericarditis with pleural effusion. Usually occurs between 2 weeks to 2 months. Okay. Yeah. And in your question, there will be a raised ESR given to help you points towards Dressler's. The treatment modality is NSAIDs. Okay. In cases of reinfarction, this is usually a catastrophic event. As it sounds, it's reinfarct, so it has to be a catastrophic event. And this will occur very quickly. If it has to occur, it will occur quickly. Let's say within 3 to 5 days of the MI. Okay, and there is no fever associated with reinfarction, of course. Okay, time could be anywhere between day 1 to 3 weeks, 2 to 3 weeks. But yes, this is the usual timeline. Okay, and pulmonary embolism can be considered, but then ESR will rule out that. And this is definitely. So this is just to check what I was telling you in the initial questions. Pressure gradient is quite something. But like I said, you always have to look for symptomatology to guide the treatment of an aortic stenosis patient. Yes, Dr. Karthik and Dr. Hiren, you're right. D is the correct answer. And Dr. Regina, you don't go with routine valve replacement. There is nothing like routine valve replacement. So, yeah, exactly. That's the thing. The patient is asymptomatic. So, Dr. Regina, you have to understand when the patient is asymptomatic, you don't have to let the patient undergo valve replacement. Okay. So, only when the patient presents with symptoms like dizziness or collapse, then you have to go with valve replacement. So, I'll just quickly write that down for you. AS. So, you have to consider valve replacement, and the word is consider. Okay, it's not a mandate. So you have to consider only when the patient is symptomatic. Okay, I hope I make my point clear. So you will be tested on this point only. Also, if the gradient is more than 50, and some of the guidelines they differ, like European Society of Cardiology says something, the value is different. But for right now, we will go with the value that the RCP accepts, and you will have left ventricular failure. Then you have to consider the patient for AVR. Okay, the last resort is balloon, and this is only in cases of patients who are unfit for surgery. Also remember that this is done with PCI if available, if planned. Okay, Dr. Regina, I hope you are now well equipped to deal with this question in a better way. Okay, that's about it. Yes, Dr. Junaid, the gradient is 40, but like I said, even when the gradient is 40, 45, 48, 50 also, let's say 50 also, usually they will not provide you a value 50. But then let's say even if the patient had the gradient of 50, but the patient was completely asymptomatic, then you will not go for aortic valve replacement, okay? You will just follow up the patient in a cardiology OPD. But if the patient is symptomatic or patient has a gradient more than 50, and failure, then you have to go with AVR. Okay. Okay, so there is some definite confusion going on in this question. This is the right answer for this one, and I'll let you know how to deal with such thing. We're talking about the Stanford classification when we are talking about type A and type B. So type B is something that doesn't involve ascending aorta. Okay, so this is type B. Okay, and type A involves ascending aorta, and it can even go further, as in this case you can see. Yeah, right. But type B is very clear, there is no involvement of ascending aorta in this one. So for type B, uh, why I'm talking type B first is because that's easier. So for type B, you do not have to go ahead with any sort of surgery. They are just involved, like managed with IV labetalol. Okay, no surgery is required usually. at least for the exam purposes. And you can also use IV calcium channel blockers, but then it's preferential to use IV labetalol in cases of type B. Now in type A, you will require IV CCBs plus surgery. That is the first line management. But surgery is the most definitive management for type A. So you basically give IV calcium channel blockers to, let me just go back over here. So you give calcium channel blockers to give the patient to the time which is required to prepare the patient for surgery. Okay, so while the patient awaits surgery, you have to give the patient with IV calcium channel blockers. So I hope that point is very clear. So in type B, there is only medical therapy. In type A, there is surgical plus medical therapy. Okay, and I hope the point is clear. All right. Dr. Junaid is really quick to answer it, and he has answered it correctly. Anyone else? Dr. Hiran? Dr. Karthik? Dr. Aisha also says C, which is right. Okay, so yes, Dr. Karthik, you're right. And observation is the correct answer. And why so? Uh, in cases of a complete heart block following an inferior MI, basically there's damage to the AV node. Okay, so this is supplied by the right coronary artery in 90% of the people. So this will recover. Okay, this resolves spontaneously, so you don't have to do anything about it. But had the stem mentioned about an anterior MI, you have to go for a pacemaker insertion. Okay, so you have to be very careful about it. The question can give you mention you things like the patient had ST elevation in leads 2, 3 and AVF, and then now the patient is showing signs of complete heart block. So what it is that you have to do? So it means basically the same. So that's how they're gonna twist the questions. The answer will remain the same. Okay. Let's talk a little bit about pharmacology here. It's very pleasing for me to see most of the questions are being answered correctly by all of you, which is absolutely wonderful. So it gives me immense pleasure. So Dr. Junaid is really quick again. Okay, Dr. Aisha, Dr. Pawan, glucagon test, then let's move on with that. And these are certain overdoses that you will encounter frequently in your MRCP Part 1 exam. I don't know about your real OPD, but yeah, the emergency department usually doesn't see beta blocker poisoning, but it's okay. ECM poisoning is quite usual. So this is what you have to remember. So I put the table. Now let's move on to the next one. This talks about the certain point that I mentioned previously in a question related with aortic stenosis. Dr. Pawan, in the management of any poisoning, we definitely use a lot of things. But the thing is, basically, they are trying to ask what is the antagonist antidote, specific antidote. For example, you would have, let's just finish this one and I'll go back and I'll let you know something. So, Dr. Karthik and Dr. Junaid say A. All right, so A is the correct answer here. Dr. Aisha seconds it with A. So coarctation of aorta is the right answer here. Let's just deal with it first. So if you look at the blood pressure readings over here, in the right arm, the BP is about 190 by 70, while when it goes down to the femoral artery, becomes 110 by 70, which is the absolute reversal of what happens. So it's very clear-cut diagnosis of coarctation of aorta. Okay, this is what exactly I was telling you when I was mentioning it before. Coming back to this one, Dr. Bhavan, yes, you're right. There are other things that we use as well. For example, if you look at this one over here, most of you will remember flumazenil as an antidote to benzodiazepine poisoning or overdose, but in real life ED, it is said that unless you want to kill the patient, you don't give flumazenil. Okay, so it is equally lethal like a benzodiazepine poisoning. So we usually, in 9 out of 10 cases, we avoid giving flumazenil to a patient with benzodiazepine, but that doesn't help with the answers, right? Likewise, when I say these are the answers, these are the answers that are relevant for RCP. Okay, so in real life, it's always like you, in cases of, let's say, in a DKA patient or something, it's not just one thing that you give. You usually give a lot of things together, right? It's not only insulin, it's not only saline, it's not only potassium, it's not only calcium gluconate, but then when they're asking about cardiac thing, then you have to answer calcium gluconate, right? When they are asking you about other effects, then you have to mention insulin and saline also. So they are basically trying to ask you one correct answer. So this is the one for your exam purposes. And you're right, Dr. Pawan. Okay. All right. So this is what a coarctation looks like. Beautiful picture. All right. I'll just mention this is coarctation of aorta. And that is why the difference in blood pressure. You see, because of the coarctation over here, you can obviously understand that the blood pressure will not be transmitted equally well downwards, right? So that's how there is a difference. And you can just go through this later on. Let's talk about this one. See, the whole idea about these questions is to let you know about the guidelines, what the guidelines say. So the focus over here of this question is somewhere here. So basically they are trying to ask which of the following drugs, or rather which all of the following drugs will definitely provide a mortality benefit as per the recent studies, given the fact that the patient already has slightly elevated creatinine levels. Yes, Dr. Junaid, you are absolutely right. And yes, Dr. Life's a kaleidoscope. I think, yeah, you're right. Yes, Dr. Erin, you're right as well. So basically, the idea is you have to add all of these four drugs in cases of an established heart failure patient, and all of this provide a mortality benefit. The ideology behind me putting this question is that some of you are not averse with the fact that spironolactone also is to be added in case of worsening heart failure. Do remember that before increasing furosemide levels to its maximal amount, try adding a spironolactone before. Okay, let's say the patient is already on 80 mg or so, then you have to add spironolactone before going any further. Okay, so that's what this question deals with. All right, you are right. Hmm. Okay, so is there some other name for Dr. Life's a kaleidoscope, because it's kind of not so useful right now. So yes, Dr. Hiren, Dr. Junaid, Dr. Aisha, Dr. Regina, and Dr. Life, all of you are right. And methyl dopa is the one that you ought to use over here. We're talking about severe preeclampsia. And if the question would say that the mother is planning to get pregnant, and initially, what would be the initial treatment for hypertension, then you would go with labetalol. Okay. Also, you can use nifedipine. These are the only two things that are licensed. Yes, but in cases of severe preeclampsia, very correctly said, you have to use methyl dopa. Okay, and the other drugs can cause IUGR and neonatal hypoglycemia, other beta blockers. So make sure that the answer only has labetalol and not the other. I'll just write it over here. Not other beta blockers. Okay. Please remember this. The other beta blockers are not licensed for use. Okay. And you don't have to be sorry, Dr. Ayan. I'll remember your name. Uh, that's quite a unique name, though. Yes, this question will let you know that there are certain questions that will come that will test a very basic thing, that is pulse, and not all of us can remember all of the pulses. Yes, Dr. Ayan, you're absolutely right. Dr. Regina, you're right as well. And left ventricular failure is usually associated with pulsus alternans. Dr. Pawan, if you remember this, you will not see this in all of the cases of LVF, right? But then this is what RCP expects of you. So always try to remember one particular answer, just one, because if you remember many, it will be very confusing for you in the exam because all of the options will be present. Just remember one answer which will be the perfect answer for that particular question. Okay. Yes. So let's see this table over here, and please try to remember this. All of the tables that I have put in, yes, Dr. Aisha and Dr. Hiren, you're right as well. All of the tables that I have put in this, the lecture notes that you can download from crackmedicine.com, these are really important this time. So I've taken the time to put it there. All right, we are heading towards the end of our session now. This is the second last, I mean the third last one. Yeah. And I expect all of you to answer it correctly again. And this is a very classic question. I'll make it a bit easier for you. Okay, so as you can see here, the sodium values are slightly less, but that's not important over here. Magnesium values are not given. And if you see here from the question stem, it's severe diarrhea and vomiting. Okay. Now, when you are, yes, Dr. Ayon, that is exactly what I'm getting at. But U waves are also seen. So like I said previously, you have to choose one answer which is non-ambiguous. What I mean is, if you choose U waves over here, they are not seen with other things like prolonged QT interval is also seen with your hypocalcemia. So then it can be confusing. That is called an ambiguous answer. Okay. So you always remember in an exam setting, like I was talking to Dr. Pawan earlier, try to remember one answer which is perfectly matching with, let's say, hypokalemia, in this case U waves. Now U waves are not seen anywhere else except hypomagnesemia. Now hypomagnesemia is not there in the options over here. So something like that, you get my point, I suppose. Remember one particular answer which is associated with it definitely and is non-ambiguous. So this will help you in the exam because all of the options will be very close. Okay, you can see prolonged QT interval is actually there. So then what makes it unique? U waves makes it unique. Okay, so I hope you get my point, and that's how you have to deal with it. So these are the changes, and Dr. Punmagar, please make sure that you go through this table, and you can see here that hypocalcemia causes prolonged QT interval as well. So that's how you have to see. U waves are also there in hypomagnesemia, but and usually hypokalemia and hypomagnesemia, they occur concurrently, especially in case of diarrhea with vomiting. So that's how it is. Okay, I hope this table is clear for you. Right, let's move on to the second last question of the evening. So Dr. Regina, Dr. Aeon, Dr. Punmaga, Dr. Ren, Dr. Aisha, and I think we're missing Dr. Karthik right now. But anyways, so Dr. Junaid, you all are right as well. The first one is always vagal maneuvers. For Dr. Pavan, you're right. So that's how you have to deal with such questions. You have to see whether, let's see, the first thing will always be to decide whether it is PSV, it's a narrow or a broad complex tachycardia. In cases of broad complex, directly have to go for, okay. In cases of PSVT, you have to decide whether the patient is hemodynamically stable or not. Okay. If the answer is no, then you have to go for DC cardioversion, right? Always remember this should be synchronized. Although it will not be given in your question, like, but then just remember, if the patient is hemodynamically stable, first go for vagal maneuvers. Okay, so when your vagal maneuvers, they don't do anything, so it is not treated, it's still present, then you have to go with adenosine. In the first instance, you have to go with 6 milligram IV start, and you can repeat this with 12 milligrams IV stat. So in an instance, always remember that initially do not give adenosine more than 18 milligrams IV stat. That's the thing. If it is not treated with this, then you have other choices as well. You can go with flecainide, but contraindication is ischemic heart disease. You can go with beta blockers, but the contraindication would be asthma. One of person asked me, when a patient is in PSVT, how can we ask the patient about history of asthma? Um, so it will be mentioned in the file usually. And the third one would always be to go with DC cardioversion. Okay. I hope this solves most of your thing. Great. So let's move ahead with the last question of the evening. Okay, Dr. Junaid, Dr. Ayon, and Dr. Punmaga says D, but why would you miss out on AC inhibitors? Okay, so the correct answer would be A. So you have to put the patient on long-term aspirin, beta blocker, and a statin. Okay, and yes, Dr. Regina, I am coming exactly to that point which you are trying to make here. After an incidence of MI, okay, so for the first 4 weeks, you have to give the patient dual platelet, that is clopidogrel, as well as aspirin. Okay, so the patient would be getting this in the first instance. Now, after 4 weeks, If the patient has had a drug-eluting stent put in place, then you have to continue with the dual platelet thing for 12 months. Okay. Okay. But after 12 months, there's no role of clopidogrel. Okay. All right. So even if the patient had a drug-eluting stent in place, then it will not be required after 12 months. Okay. Always remember that initially you will give statin, ACE inhibitors. These are all the drugs that have proven mortality benefit. Okay. Actually, let's not go in that order. Let's go in the order that we give the drugs. Okay. So these two you will decide after the patient has stabilized. Okay. I hope the point is clear. Okay. So if the patient did not have, if the patient was not on drug-eluting stent, then you will continue with aspirin only. Okay. Okay, I hope all the points are made. Great. Dr. Junaid says I said A. Okay, Dr. Junaid, I think I mistook your thing. You are absolutely right. So uh, also one more thing, in cases of non-ST elevation MI, clopidogrel plus low dose aspirin should be continued for 12 months. Okay, in whom you are suspecting like mortality or high risk of MI, you have to continue this for 12 months. Okay. So thank you guys. All of you were really wonderful. Dr. Junaid, Dr. Pawan, Dr. Hiran, Dr. Regina, Dr. Aisha, Dr. Aon, Dr. Punmagar, Dr. Kartik Priya as well. Dr. Pawan, I hope all of you were really amazing today. And most of your answers are correct. That shows that you are all on the right path. So continue studying and revising. And I hope all of you also enjoyed with me the way I enjoyed being with you guys and learning so much from you as well. So let me know in the comment section if you liked or disliked anything. Please put on a like in the video as a gesture of goodwill to us, and go to crackmedicine.com and you can download the notes from there. And that's pretty much it. See you again next week. We will be updating the schedule for the next week classes. It will be delayed by a week or so. So please note that. And we are there for you. Let us know anything. And also please drop us a feedback. We really are in need of feedback. So thanks a lot for your time and have a good day and good evening. Bye.